I'd like now to invite Dr. Janey Wiggs to present on using genetics as a management tool for glaucoma. Dr. Wiggs is professor of ophthalmology at Harvard and Mass Eye Ear.
Thank you. Yeah, it's really a pleasure to be here. I have to agree with David that it's a little daunting to have Ruth Bader Ginsburg staring right at you while you're giving your talk. And I'm really excited about adding genetics to these, great talks that we've heard this morning about all the different ways to assess glaucoma patients, because I think that genetics is a tool that we should be using hand in hand with all of our other clinical tools. So my other support is not relevant to this talk. So, we've all understand a lot about the disease glaucoma. I just want to emphasize here with this picture that going from the healthy eye with the healthy optic nerve to the disease optic nerve is, of course, what we all want to prevent in people who are at risk for glaucoma. But it's always not easy to determine who's going to make that change and who's going to progress to that advanced disease. Who among those people with the healthy optic nerve are actually at increased risk for glaucoma. And as a result, our screening tests are not perfect for the population. And as a result, there are many patients who have glaucoma that are actually undiagnosed. So genetics to the rescue. It's interesting, glaucoma is actually one of the most heritable of all human conditions, which is kind of fun for us who specialize in this field, and also actually very helpful that there are so many genetic risk variants, or that the genetics is so strong for the disease that we really can capitalize on this incredible association. So what can we do with genetics to help us with our endeavors? Well, if you identify genes, genes, you've pinpointed these genes that cause disease, we can use those for genetic testing to identify people who are at risk for glaucoma. So people who are carriers of risky genes or risky variants in genes are people that you would want to know who they are because they are increased risk for disease. And then also, of course, kind of probably the holy grail still in glaucoma, but certainly something, that we keep in mind is that these genes also represent potential targets for novel gene-based therapies. Now, I'm sure you're all aware that, glaucoma covers the lifespan, and actually all forms of glaucoma, well, maybe not all, but the majority of glaucoma is inherited, including the early onset forms like congenital glaucoma and juvenile glaucoma and these kinds of things. These early onset diseases are usually present in children, and they're caused by rare mutations in genes that have very large effects. So you have one of these mutations, you have the disease, and as a result, those mutations are transmitted in families, and we find families who are affected with these kinds of conditions. These were the first types of glaucoma that were first studied genetically, 20, 30 years ago. And we're using kind of the basic technology at the time then, linkage studies. Now we can look at these families and do whole exome sequencing, whole genome sequencing to identify the important gene variants. We have about 12 genes that are known to cause these early onset conditions. In contrast, the adult onset diseases that you're all much more familiar with have, like primary open-angle glaucoma, for instance, have complex inheritance. And what that means is that a single gene variant that is associated with these diseases is not sufficient to cause disease. But in aggregate with other gene variants, or even in some cases environmental conditions, the disease threshold can be reached. So as a result, we really don't have families here. We generally have cases, people with glaucoma, and we have controls, people without. And this kind of population, cases and controls, is amenable to doing things like genome-wide association studies. As a result, we also have many, many variants, genetic variants that are associated with these conditions. So I'm going to talk about both, how we use genetics for both of these groups, the early onset and late onset, spending most of my time on the late onset, but a couple of points about the early onset. First of all, in these families who have these early onset types of glaucoma, genetic testing can be very important if we find a variant, because we can then identify everyone in the family who has this mutation. So we can target surveillance, to people who are actually mutation carriers, rather than having to drag the whole family in, several times a year to look for disease development in people who may or may not have the mutation. So that's a huge thing for these families, especially with small children. In addition, we can use the genetic information to inform genetic counseling. So oftentimes people will ask us, what is the risk of having another child with this condition? If we know the gene and the mutation that's caused that problem, then we know how it's inherited and we can advise on genetic risk and genetic counseling. Also, it's important, some genes have comorbidities. PAX6 is located near the gene for Wilms tumor. People who have large deletions, chromosomal deletions that include PAX6 can also have Wilms tumor. So it's important, to know which gene is actually causing the problem. And then eventually, we're really super hopeful that at least some of these genes will be targets for gene-based therapy. And gene-based therapy, of course, depends on knowing a molecular diagnosis before you initiate the therapy. So we have a limitation with early onset glaucoma in that currently these 12 genes that we have only account for disease in about 20% of patients. And this is in a group of patients that's defined as disease onset before age 40. So we're missing a lot, probably we're missing a lot of just genes that haven't been discovered yet. We're doing a lot of active work in this area to identify new genes using, sort of state-of-the-art cutting edge disease approaches and whole genome sequencing, and also using populations that are more ethnically diverse than have been studied in the past. These kind of approaches have led in the last couple of years to 2 new genes that we've discovered, EFEMP1 and thrombospondin1. Both of these, interestingly, are in the extracellular matrix of the trabecular network. And of course, that's a busy place with a lot of proteins and other potential genes that could be involved in these processes. And there are some emerging therapies, just to note. People with myocilin mutations can benefit potentially from disruption of the myocilin gene using things like CRISPR, and we're hoping to see that kind of progress in the next few years. Also, a couple of other genes, TAC and angiopoietin-1, can benefit from sort of enhancing that signaling pathway and getting it to move a little bit better. And then, of course, PAX6 and aniridia, there's been a clinical trial using a drug that causes a read-through of mutations. So moving now then to the adult onset diseases, where, again, just to remind you, there are many, many genetic variants that we find responsible for these conditions when we do genome-wide association studies. So this is one that we published in 2021, where we identified 127 different genes that can contribute to primary open-angle glaucoma. In this slide, this is called a Manhattan plot, and each of those little dots are a genetic variant that's associated with disease. So how can we use something like that, all of these hundreds of genetic variants for genetic testing? Well, one thing that I just want to emphasize is that unlike the early onset diseases where a single variant can, determine health or disease, for these late onset, genetic variants, individually, they have small effects, but in aggregate, they reach the disease threshold. So it doesn't make sense to test one of them at a time. Instead, we need to test a group of them to see what kind of overall genetic burden a person has for these variants that have been discovered. Now, recently, in the last few years, the way that that is done is through the calculation of something called a polygenic risk score. And this is a really important emerging technique that has been used not only in eye diseases, but also cardiovascular diseases, cancer, Alzheimer's disease, many other diseases with this sort of complex inheritance pattern where we can calculate overall genetic burden using this approach. Basically, the way this works is we take all of the genetic variants that we identify through these genome-wide association studies, we add them up in a person, and then we determine where that person ranks in their population. So for example, in this room, we could, genotype everybody in this room, add up how many variants everybody has, and then we could just array the room from the lowest number to the highest number to identify the distribution. People with the highest number of variants, therefore, are expected to have the highest genetic burden of these variants and therefore be at increased risk for disease. And so in this instance, we usually look at people who are, say, in the 90th percentile of this distribution compared to people who are in the lowest percentiles to understand the contribution of this high genetic burden to disease. So, oh wow, is this a communal glass or just, okay. You just had one all teed up for me, okay. Thank you, guys. Okay, so in the very beginning of looking at this aggregate polygenic risk, Jamie Craig and together with our international colleagues looked at the impact of high polygenic risk on different features of disease in glaucoma cases. So what we found in that study is that patients with the highest genetic burden had earlier age of diagnosis, so 5 to 10 years earlier than people in the 10th percentile, thinner near fiber layer thickness, so much thinner than people in the 10th percentile, and a greater need for trabeculectomy or surgical intervention to control intraocular pressure compared to the 10th percentile. More recently, our colleagues, together with our colleagues at Mass Pioneer, we've looked at using a polygenic risk score to look at prevalence of glaucoma in a large population database, the UK Biobank. And here we found that people in the 10th or the top percentile, the 90th percentile, are much more likely, 7 times more likely to have glaucoma, have a diagnosis of glaucoma in that biobank compared to people in the 10th percentile. Also, in other studies done by our Australian colleagues, people with higher polygenic risk scores, so in the 90th percentile, had faster visual field progression compared to people in the lower percentiles. And more recently, this paper is actually out now, it's no longer in press, but more recently we have found that if we look at the OATS population, the ocular hypertensive treatment study, so these are people that have been followed now for like 20 years with high intraocular pressure and followed for conversion from just being an ocular hypertensive to actually having damage to the optic nerve, we find that the people who are more likely to develop damage to the optic nerve are the people with the highest polygenic risk scores. So again, predicting worse disease, more severe disease. Now, this is all great. We've learned a lot, but a few years ago, Dr. Pasquale and I were having coffee at a meeting, and we asked the question, well, what is really the clinical impact of having a high polygenic risk score? So what we had learned so far is that if we look in glaucoma cases, they have more severe disease. If we look in populations like the UK Biobank, we find an enrichment of disease, but we can't examine those people in the UK Biobank. And the UK Biobank is defined by things like ICD-9 and 10 codes, so we really don't know what we have. So what we want to know is the polygenic risk score a useful risk stratification tool? In other words, if we take a population of people who's going to come into our clinic and we calculate their polygenic risk score, is that going to help us decide how to treat that patient or how to follow that patient or, whatever else? So specifically, we asked, what is the glaucoma prevalence in people with high versus low polygenic scores? And are there undiagnosed cases that we pick up? We know there are so many undiagnosed cases roaming around. Can we find those people by using this genetic approach? And also, what are their clinical features? So we did a study to address this question. I should say we're doing the study, but I'm going to give you the interim results. So the study design is that we calculated this polygenic risk score for about 54,000 people from BioMe at Mount Sinai here in New York City, an enterprise that Lou led, and then about 45,000 people in our equivalent kind of biobank at Mass General Brigham in Boston. We identified the people who were in the top and the bottom deciles of these populations, and we invited them to come into our clinics for an exam. So we can determine what they actually have. Do they have glaucoma? What are their features? So this is the exam we did. High or low PRS score. The clinical examiners and coordinators and everybody are completely blinded, of course, to the score. These are all the measures that we did, which are all kind of standard and things that you would expect. But we did a pretty detailed assessment. We didn't do angiography, OCT angiography, but we did do OCT and retinal nerve fiber layer thickness. And then once the exam is over, 2 examiners got together and decided on a diagnosis of glaucoma or not, and then the polygenic risk score was revealed. So what did we find? Well, to start with, the demographics, interestingly, of the high versus low polygenic risk scores is pretty similar in terms of age, gender, and even ethnicity. We found in terms of clinical features that the high polygenic score had evidence of glaucoma-related traits compared to the low group. So they had higher intraocular pressure, lower corneal hysteresis, and lower mean deviation on visual fields. But I think the most striking thing that we found so far is that the people in the high polygenic risk score have a glaucoma prevalence of almost 35%. This is tremendous enrichment when you think of the prevalence of a 60-year-old in the population. Compared to the low PRS, which was also a little higher than we might expect, and we can talk about that in the question and answer, but compared to the low PRS, this is incredibly statistically significant. We found this at both sites. So the nice study section is, or study design is that we can look at both sites as kind of a validation. Both sites had this high prevalence of disease. I think, interestingly, we found this high prevalence in various ancestry groups that we had available to study. Some of our ancestral groups are currently still underpowered, but for those that we were able to look at, we found this high prevalence of disease in people with high polygenic score. And I think one of the most exciting things is that 50% of the people we diagnosed with glaucoma in the high PRS group in this study were previously undiagnosed. So these are people that are wandering around with glaucoma. The only reason they were diagnosed is because they entered our study, we calculated the score, and they came in for an exam. So to me, that's a very kind of exciting result. And using a logistic regression analysis where we included a lot of variables and so forth, we found a very high likelihood odds ratio of developing glaucoma if you have this high PRS score. So to summarize this study, I think what we have found is that individuals with high polygenic risk scores are more likely to have a diagnosis of glaucoma compared to those with low. 50% of these people, when we screen this kind of hospital-based, community-based population have undiagnosed glaucoma, and that individuals with this high PRS are more likely to have clinical features that we would expect of glaucoma patients. So, in general, using genetics as a management tool for glaucoma, in early onset glaucoma, we can identify carriers of these high impact mutations, allowing for surveillance and early treatment. We have some limitations. Diagnostic yield is one, but we are finding new genes which will help with that. And then in terms of adult onset people with high polygenic risk testing, we can show that this is potentially a useful screening tool. That you can imagine screening a population for genetic risk factors, identifying people who have high polygenic risk, then those are the people that we should bring into our clinics for more in-depth testing using our definitive tools that you've heard about earlier this morning. So I'm just going to acknowledge a bunch of people. These are the International Glaucoma Genetics Consortium that led to that genome-wide association study that we used to derive the polygenic risk score. This is our group that's working on this polygenic risk score project, which has just been a superb group of people to work with, and at Mount Sinai led by Lou Pasquale. And then these are people in my lab who have worked on some of the other projects that I briefly mentioned. Thanks.